from Ocala, Florida. Thank you for tuning in. Thank my friends and colleagues who watch this. And I've been streaming weekly, talking mainly about cataract surgery, but also different MIGS devices and different things in the world of cataract surgery. So this is an interactive series. I will post videos based on requests from viewers. And if there's anything you want to see or learn about in particular, please comment and let me know. We're streaming on multiple platforms, so I will try and keep up with the different messages and anything that you may want to comment on. So this week I want to talk about we're going to show a case of cataract surgery, but post-operatively I'm going to instead of using our regular drops, we're going to use Dextenza punctal plug, which is a punctal plug that secretes dexamethasone. All right, very good. Okay. So, like I said, we're going to talk about cataract surgery, and at the end of the case, I'll show the technique for putting in the Dextenza punctal plug. So we can see in this case, we have a really nicely dilated pupil. We have some anterior cortical spoking. The cornea looks fairly dry, which my assistant, I'm sure, will take care of here shortly. We use the side port blade to make our paracentesis incision. I tend to make this closer to my main wound, I think, than most people, and that helps me when I do a phaco chop. Typically, divide and conquer technique will require the paracentesis to be a little bit further away, a little bit more closer to 90 degrees away from the main incision. I injected 1% preservative-free lidocaine, and then followed by dispersive viscoelastic. In this case, it's Viscoat. And here we use 0.12 forceps and the 2.4 millimeter keratome blade to make the clear corneal incision. Once again, I really like to use those 0.12 forceps to fixate the globe. It really takes a lot of the stress out of this part of the procedure. For a lot of surgeons, especially starting out, making the capsulorhexis will really determine the outcome of the rest of the case. If you have a good capsulorhexis, then you set yourself up for success. If the capsulorhexis runs out, then it can make the rest of the case significantly more challenging. So by using these 0.12 forceps, you can see the globe here is perfectly stabilized, and of course, all these cases are done under topical anesthesia, and you can see the patient does move periodically. But having the 0.12 forceps really just takes out the stress of that part of the procedure. And then we go in with BSS on a hydrodissection cannula, and very important for this part that we tent up the anterior capsule. And then I also do hydrodelineation. And you can see I don't really spend too much time spinning the lens or any such maneuvers. But very important to tent the capsule. That makes, in most cases, makes the irrigation aspiration a lot easier to do. And most of the time, a lot of the time, we're able to achieve cortical cleavage. So here we go with the phaco. I do I basically bore a core out centrally. And I go in with a Niekemann chopper, and we go into our next mode, our burst mode, and basically start chopping the nucleus. We use a phaco chop maneuver, and so we initially chop the nucleus in half, and then we've got it now in quadrants. Typically, I go for the other quadrant first, but I think in this case, the quadrant on the right-hand side came up first. So we just take what we get. Then we rotate. You can see, even though I didn't spend a lot of time trying to rotate the nucleus initially, that it does rotate fairly decently. and then the other quadrants just readily come up. This is using Stellaris, using the burst mode, which gives you the same amount of phaco energy no matter how far you push down on the pedal. Pushing down the pedal just increases the frequency of the phaco bursts. And I've been using this mode pretty much since residency. I really like the way it holds the pieces, and it really does lend itself well to doing phaco chop. And then this is really just removing the rest of the cortical material here, and not so much the cortical material, basically the epinuclear shell, and we got that out, and now we are left with some cortical material here. So sometimes we get good cortical cleavage, sometimes we don't. And the nice thing about live streaming is that, you know, these cases I really haven't reviewed them too closely beforehand, and so we can just get commentary on what's happening. So here I'm just basically taking away. You can see that I had a small nuclear fragment there, and that was at the wound. I typically like to get those first, or even if I don't, they just tend to come to the tip first. And then we remove the remaining cortical material. I use a silicone tipped IA. Nothing really out of the ordinary here. There's a small nuclear chip there that you can see at the tip of the IA, and I am flooring the vacuum, and it's not going in. So I go in with a Connor wand, and I smush that into the IA tip. And now I'm removing cortical material. Remaining cortical material is there. I reach in the fornix just to clean up. Really want to leave as little as possible here. We want to leave as little as possible here, just to decrease any kind of residual inflammatory reaction that may result, decrease inflammation that's present post-operatively. So here I'm just spending some time doing that. There is some material there subincisionally as well, it looks like. Okay, and now I'm going in with a silicone tip Terry squeegee, and we're basically polishing the posterior capsule. So if you're just tuning in, basically this is a cataract surgery followed by placement of Dextenza, a Dextenza punctal plug for control of postoperative inflammation. The main advantage of doing a Dextenza punctal plug is to decrease the topical drops the patient has to be on postoperatively. We're finished here with capsule polish, and we're placing a cohesive viscoelastic to fill the capsular bag and to pressurize the globe in anticipation for intraocular lens placement. And here comes the intraocular lens. We're using a wound assist technique. This is a one-piece hydrophobic acrylic IOL. And we use a Lester manipulator here just to rotate the IOL into position. I like to see that the haptics are free from the optic because that can sometimes take a little bit of time. So I just like to manually free them. Removing viscoelastic, we go behind the intraocular lens. And then we go in front of the intraocular lens. And we'll spend a little bit of time here just removing the viscoelastic. Doing a good removal of the viscoelastic will decrease the likelihood of a post-op day one pressure spike. And then we want to make sure that the lens spins freely. There's no more cortical material in the fornix. And so we'll spend just a little bit of time cleaning that up as well. So we're just continuing to remove any cortical material that may be present. Spinning the lens, making sure that it spins freely. I typically leave the haptics oriented at 3 and 9 o'clock. I'm not sure there's really an optimal placement. I try to do that in hopes of decreasing negative dysphotopsias postoperatively. I'm not really sure that it makes a difference. And then we're using BSS here to hydrate our main incision to achieve a watertight closure. We'll hydrate the main wound, check pressure, and now we're going to hydrate through the paracentesis and hydrate the paracentesis. I check the pressure with the BSS cannula. Use the technique that's most comfortable for you. I see surgeons who use their finger just to tap on the cornea, but I just like using the back of the BSS cannula. And then we check the wounds, make sure they're watertight. And then I just like to press on the globe just to make sure that everything is nice and watertight and we're happy with it. So it seems like I am. So at this point in time, I'm going to remove the lid speculum, and then we're going to remove the drape from the patient, and then place the Dextenza punctal plug. I think this may actually be my first case with the Dextenza, and that's why I'm kind of just looking and seeing what the visualization is like before actually removing the drape. But if I recall correctly, I think I will go ahead and remove the drape here. Alright, so I think all we're doing here is just removing the drape and getting the patient set up for this. I'm going to fast forward a little bit here. Okay, so we got the drapes removed. I'm looking at the, I'm drying the lid here. So this is sped up at 2 times the speed. And I'm explaining to the patient, you know, what we're doing here. So I'm first of all going to use a punctal dilator to dilate the lower punctum. And so we're applying traction to the lid and pulling the lid inferiorly. And that's the direction that we're going to dilate in towards the nose. And then there's a Dextenza punctal plug. You want to grab it right at the very tip so you can insert the entire plug into the punctum. And just play this at regular speed. So basically, as it goes in, you want to inject towards the nose, and it's nice to get this all in one motion because my understanding is it does swell up pretty quickly once it gets hydrated. And that's really about it. You can see the entire thing goes into the punctum, and the patient will have good steroid coverage for the rest of their post-operative period. I'm just starting with this technology. Colleagues who have used it have reported that they like it. These patients are now just getting moxifloxacin or an antibiotic 4 times a day for a week. And that's really about it. So I'm not sure how many of y'all have done Dextenza or what your experience is with Dextenza or using, or what your post-operative regimen is. I've been happy with our post-operative regimen at this point. Currently we're using a combination of antibiotic, steroid, and non-steroidal compounded force. And I've been doing a 4-3-2-1 taper 4 times a day for a week, 3 times a day for a week, twice a day for a week, and then once a day for a week, which is a 4-week regimen. I've been happy with that, but always when it comes to surgery, we're always looking for ways to innovate and ways to make things easier and simpler for our patients. A few years ago, this was not the regimen. We had patients taking 3 different bottles of drops, and each drop had its own regimen, which we had charts and everything, and patients would report that the charts were easy to follow. But still, if we can make things easier for patients, we should definitely try to do that. So hopefully with Dextenza, what we're going to be doing is just moxifloxacin 4 times a day for a week. And that's it. We'll be still watching the patients for any kind of rebound inflammation, and obviously supplementing with steroids should that occur. So that's really it for this week. We showed cataract surgery with a Dextenza punctal plug. Please feel free to comment or give me your experience with Dextenza, or what your preferred cataract surgery technique is, or thoughts on what you'd like to hear about in the future, or what you'd like for us to talk about in the future. So thank you for tuning in. I appreciate your support, and I hope that this is something that's useful for you, and that it's something that can spur some discussion and something where we can all learn from each other. Hope everyone has a fantastic week ahead. All right. Good night.